Hi, this is Samantha Littman, and I'll be presenting this case study on Gaucher disease. The case study that was presented involves a 49-year-old Jewish female complaining of increased pain in the right leg and hip, as well as some recent abdominal discomfort. Her medical history indicates that she had some mild splenomegaly during her third pregnancy at age 30, but was otherwise unremarkable. A family history indicated that she has a younger brother who complains of back trouble, but otherwise her 3 children and 2 siblings are healthy. Upon examination, the patient presented with marked splenomegaly, low platelet count, anemia, lytic lesions and pathologic fractures of the right femoral head and neck, and an Erlenmeyer-Flass deformity of the distal femur via radiologic evaluation. The treatment for this patient included a platelet transfusion, bone marrow biopsy, frozen section diagnosis of the bone marrow, a splenectomy, and a right hip replacement. Gaucher disease is an autosomal recessive condition in which there is a mutation in the gene that encodes for glucocerebrosidase. The mutation causes this enzyme to accumulate in phagocytes, expanding the liver, spleen, and bone marrow, as well as an increase in cytokine production. The discussion questions are as follows. What was seen on the frozen section of her bone marrow biopsy specimen? On the frozen section of the patient's bone marrow biopsy specimen, the development of Gaucher cells can be seen. These cells are taking over the patient's bone marrow space. They are enlarged macrophages filled with the glucocerebrosidase enzyme. What caused her symptoms? The patient's enlarged spleen, lytic lesions, and pathologic fractures of the femoral head and neck are caused by the development of Gaucher cells, enlarged phagocytes accumulating in the spleen and bone marrow. In both areas, there is an enlargement, which causes the fractures and the pain that the patient was experiencing. The patient's low platelet count and anemia are secondary to the organ enlargement. What type of Gaucher's disease does the patient have? What are the other types? This patient has type 1 Gaucher disease. Type 1 is the chronic form of the disease in which the brain is not involved. This type primarily occurs in Jewish individuals of European descent and has splenic and skeletal involvement. It is also the most common form of the disease. Glucocerebrosidase are stored in phagocytes throughout the body and causes a decrease in the level of this enzyme activity upon laboratory examination. Type 2 is the acute infantile form of the disease, characterized by central nervous system involvement and no detectable glucocerebrosidase activity. These individuals will also present with hepatosplenomegaly, enlargement of the liver and spleen, and leads to death at an early age. Type 3 is the combination of type 1 and 2. This typically affects adolescents and young adults and is characterized by progressive central nervous system disease as well as systemic involvement. Are her siblings and children likely to have Gaucher disease? Gaucher disease is an autosomal recessive condition in which mutated genes need to be inherited from both parents in order to inherit the condition. Because this patient has the disease, she must have inherited the mutation from both parents, making it possible that her siblings could have the condition or be carriers of the disease. In order for the patient's children to have the disease, they would also need to inherit the condition from both parents. In order to know if they could have the condition or be carriers, the father's information would need to be present. How is Gaucher disease diagnosed? Gaucher disease can be diagnosed definitively via laboratory workup measuring glucocerebrosidase enzyme activity. Patients with Gaucher disease present with enzyme activity that is lower than those of healthy individuals. The disease can also be diagnosed via skin cell samples and bone marrow biopsies, checking for the Gaucher cells. The abnormalities in the condition can be seen with blood tests and radiologic examinations such as X-rays, MRIs, and CT scans. How is Gaucher disease treated? Currently, Gaucher disease is being treated by replacement therapy of recombinant enzymes and is effective for patients with type 1. The disease can also be treated with the transplantation of allogenic hematopoietic stem cells. The first article critiqued in the Gaucher case study is called Mapping the Genetic and Clinical Characteristics of Gaucher Disease in the Iberian Peninsula. More than 300 mutations, including point mutations, deletions, insertions, splicing, aberrations, and various rearrangements, have been described in the glucocerebrosidase gene region as the cause of Gaucher disease. In this study, they looked at demographic and clinical data from all of the referred patients with Gaucher disease registered in Portugal and Spain. They looked at the patient's age, sex, ethnicity, GBA genotype, country of origin, age of diagnosis, organomegaly, spleen status, cytopenias, hemoglobin, ferritin, and gamma globulin levels, severity score index, type of treatment, years of therapy, and whether the patients were alive or deceased. Full GBA gene sequencing was not performed for all patients. They were screened for specific mutations and used long-chain PCR and nested PCR or PCR reactions to detect mutations. The results of the study are as follows. They included 436 patients in the study. 88.3% had type 1, 6.7% had type 2, and 5% had type 3. They identified 69 alleles and 66 mutations that cause Gaucher's disease. Most frequent genotypes were N370S and L444P, which involves 27.9% of the patients, as well as 9370S, which involved 14.8% of the patients. This shows that there are common gene mutations that are causing the Gaucher disease. While there are multiple that cause it, these are the most common. The second article is called Enzyme Replacement or Substrate Reduction, a review of Gaucher disease treatment options. It was a literature review of multiple databases, including the Cochrane Review, CINAHL, IPA, and PubMed, as well as current clinical trials from clinicaltrials.gov. The article reviewed the current therapies for all three types of Gaucher disease, but focused primarily on type 1. The treatments were as follows. Enzyme replacement therapy is the preferred therapy for type 1 Gaucher disease. It works by supplementing the deficient or defective acid beta-glucosidase to break down the glucocerebrosidase into glucose and ceramide, which accumulates in the macrophages in the absence of the acid beta-glucosidase. These are the two that they found a theoretical lower risk of immunogenicity reactions or antibody development. The second treatment was a substrate reduction therapy, which is considered if unable to receive or tolerate the enzyme replacement therapy. The substrate reduction therapy reduces the glucocerebrosidase influx into the lysosome by inhibiting the glucocerebrosidase synthase enzyme, resulting in a reduction of the amount of the glucocerebrosidase present. This therapy shows a higher incidence of adverse effects and should also be avoided in men and women trying to conceive. There are no current approved therapies for type 2, and 3 Gaucher disease, but enzyme replacement may help with symptom management. The final article reviewed is called Diagnostic Methods for Gaucher disease. Gaucher disease is a condition in which glucocerebrosidase accumulates in cells and some organs, causing a deficiency in the enzyme. Laboratory testing can be done to test for Gaucher disease. They can use an assay that measures glucocerebrosidase enzyme activity. Enzyme activity is low in patients with Gaucher disease, most showing 30% or less activity. Skin samples can also be taken from patients, looking at the fibroblasts, and they can measure the amount of glucocerebrosidase levels from the fibroblasts. They can also use bone marrow biopsies and look for Gaucher cells under a microscope. Abnormalities can also be seen via laboratory testing, such as low red blood cells, low platelets, signs of chronic inflammation, and liver dysfunction. Radiologic evidence includes early skeletal changes, such as an Erlenmeyer-Flass deformity of the distal femur, lytic lesions of the long bones, ribs, and pelvis, pathologic fractures, osteosclerosis, and osteopenia. Bone abnormalities and organ enlargement can also be seen via X-rays, MRIs, and CT scans. Family members should be tested to determine if they are carriers of the disease or have the disease themselves, and DNA samples can also aid in the diagnosis or screen for carrier status.